Welcome to The Pharmacist RN, a podcast made for pharmacists by pharmacists. Pull up a seat and let's get started.
We're back. I can't get over that theme music, eh?
It's epic, and what I feel, it stimulates my sympathetic nervous system, so I want to learn about pneumococcal disease.
Come on, man. Gets you fired up. I actually think we're going to hear Steve Angelo open with that at Tomorrowland. I really believe he's got a beat there, and that was made custom for us.
That's very kind of Still Young to do that, and yeah, no, I would be very excited. If I was watching, if I was at Tomorrowland in 2015, if that came on, I would be ready.
Imagine that.
Yeah.
And then just put our logo in the background behind Steve. That'd be epic. But we're not at Tomorrowland. We're here in the studio and we're talking about pneumococcal disease.
We are, and it is a respiratory disease that is, to put it lightly, it's poorly understood by patients and poorly understood by providers.
Oh yeah. Like, I mean, I think of all of them, even RSV, I think gets more press than pneumococcal disease.
Oh, definitely.
Like, that's
definitely
relatively new in the adult space.
It is, and we're going to talk about that in the next episode. Yeah. But it's funny, pneumococcal disease. So, just a little quick scientific whirlwind here. Pneumonia is an infection of the lungs, right? So that could be COVID, that could be influenza. We talked about that in the last episode. If you want to learn more about that, check out the previous episode. It could be RSV. Yeah. And with viral pneumonia, it tends to be both lobules. Yeah. Like it kind of goes everywhere. But if it's localized in a particular area or one lobule, it's bacterial. Yeah. And the most common cause of bacterial pneumonia, Streptococcus pneumo.
Yeah.
So that is pneumococcal disease, is pneumonia caused by bacterial infection known as strep pneumo. Strep pneumo hangs out in the nose and the throat. A lot of kids have it. It's great that kids are getting that vaccine when they're younger. It's been shown to reduce transmission to adults. And it can also be a secondary infection. So you get the initial COVID, influenza, RSV. It disturbs your lung parenchyma, kind of messes everything up. And then some uninvited party guests creep down from the nose and throat. Strep pneumo, and that bacteria comes in there. So that's sort of the Bill Nye the Science Guy whirlwind tour of pneumococcal disease. Now, there's a little bit more to it, where that pneumococcal disease is in the lungs, but then, and you've talked about this in your presentations, invasive disease.
That's right.
It goes from a non-sterile site into a sterile site, which is the blood or the cerebral spinal fluid, and that is bad news.
Yeah, we're talking about serious potential complications and consequences to the patient. And I know Dr. Gorfinkel, who I do a lot of radio with, colleague and friend of mine, and she always emphasizes, and I said in a previous episode, lung disease begets more lung disease. And that's her line. And when we think about our chronically ill, comorbid patients, multiple chronic disease, these patients, they're at risk for everything.
Yes.
For COVID, for influenza, for, pneumococcal disease. And if they've had previous pneumonias, viral, they're at higher risk for pneumococcal pneumonia.
Oh, definitely. Yeah. We know they're susceptible. Like you said, lung disease, it all compounds. Now, vaccination, obviously what's really wonderful is for these viral assaults on the lungs, COVID, influenza, RSV, it's preventative options.
Yeah.
And there is also preventative options for pneumococcal disease, which is fantastic. So fantastic that there is what we call the 80% challenge, John.
Yeah.
The 80% challenge is a learning program that we developed. It's available online. Link is in the podcast episode. And it's based on the fact that the goal from the PHAC, Public Health Agency of Canada, is to vaccinate all high-risk adults against pneumococcal disease.
Yeah.
And that includes adults over 65. It includes adults 50 and over with comorbidities, which is pretty much every patient at the pharmacy. If they're over 50, they're taking medication. And those 18 over who are immunocompromised.
That's right.
But focusing on the bigger groups, which is 65 and over and 50 plus with comorbidities, we're nowhere near that 80% mark.
No, and when you look at that, because that data is, it's included in every presentation.
It is,
that someone does on immunization. And that's where the biggest gap is in the, in the patients that we're looking at who have been vaccinated against pneumococcal disease, very low. What's the number this year? Does anyone know? Or
Well, I think like it was trending up before the pandemic, but after the pandemic, I mean, we're closer to probably 50% than we are to 80%.
That's a huge gap, and it's it's frustrating because there's a lot of reasons for it, eh? And I think I'm always think, okay, what's going on? I mean, I think there's the potential funding issues, and we talk a lot about that, about whether vaccines covered or not. But we know time and time again, the data tells us healthcare professionals overemphasize the barrier of cost. And I think I see it in my practice. I think we don't want to go down that rabbit hole. We don't want to get into a discussion about costs. We don't mention a vaccine, but when you ask the patients, what's the biggest reason you didn't get vaccinated? What is it?
Nobody told me.
No one told me.
Nobody told me.
I didn't know. If you told me, I would have done it.
Yeah,
right?
yeah.
So I think from our perspective, it's making that strong recommendation, getting out there, telling patients about the vaccine, because many of them don't even know a vaccine's available. And when you survey patients, they've heard of pneumococcal pneumonia.
Yes. Yeah.
But they'll tell you, well, I didn't know there was a vaccine, but I know it could be potentially serious.
Oh yeah, they know and they fear it, but
Yeah.
they don't know there's a vaccine available.
Yeah.
So in the 80% challenge learning program, we kind of identified three domains to get that behavior change where they're recommending it and administering it and protecting their patients, thereby getting closer to 80%. The first is capability. So understanding what is pneumococcal disease. But I think so we kind of went over that earlier, but there's also another layer is understanding the vaccination options. A little bit confusing.
Yeah. And maybe we'll talk about that because there is now another alternative, I mean, and I think over the last few years, we've done quite a bit of education, but there's been a lot of change in this space, right?
Mm-hmm.
So you want to give the 2-minute Coles notes?
2-minute Coles notes. So for a good vaccine for pneumococcal disease, you want two things. You want broad serotype coverage, right? So that's called valency.
Yeah.
The more serogroups included in the vaccine, the higher the valency. And what the serogroups do is the vaccine targets the polysaccharide coat.
Yeah.
So these disease-causing serotypes of strep pneumo, and there's over 100 of them, but there's only a few, there's less offenders that cause disease. So by giving the vaccine, your immune system recognizes that code and is able to neutralize it, which is good. So more valency is one criteria, but also there is conjugate versus polysaccharide.
That's right.
So I mentioned polysaccharide coat is the polysaccharide 23 vaccine, Pneumovax 23. 23 serotypes, but it's just a polysaccharide. And when I say just a polysaccharide, that means you're only presenting the coat antigen. Yeah. But if you take that polysaccharide and covalently bond, little grade 9 chemistry right now, covalently bond that to a protein, you get a much more robust immune response that produces more IgG, which is longer lasting, and mobilizes more of the T cells, which are extremely vital in fighting infection. So that's why we have conjugate vaccines. So pneumococcal polysaccharide, Pneumovax, and then you've got pneumococcal conjugate, Prevnar 13, and now what's available is Prevnar 20. So 13 expanding the valency is Prevnar 20. But we'll kind of make this clean here, is basically NACI recommends, as per their 2023 statement, at this time, at the recording of this podcast, the pneumococcal conjugate, the PCV20, Prevnar 20 vaccine, is strongly recommended for those who are naive, so they've never received any pneumococcal vaccine. And it's also recommended for those if they've received a pneumococcal vaccine, if it's been about at least a year since their last dose.
That's right. And there's that other scenario, which we do have patients in that, who have received polysaccharide and they received Prevnar 13. What is that?
Oh, yeah, that one's an interesting one. So we can kind of give the more comprehensive answer. There's different guidelines that say different things. NACI, for example, says you can wait up to 5 years. Yeah. Most of my patients, it's been more than 5 years. So it's kind of redundant, but pharmacists love a palate cleanser. Yeah. So other guidelines say a year is fine. So if it's been a year since they had a pneumococcal vaccine, there are guidelines that support the fact that giving them the most updated conjugate vaccine is totally okay to provide that additional protection.
And, we talk about pearls a lot on these podcast segments, but I think you hit on a big one here, because the question you inevitably get if you present on this topic to pharmacists is, well, I thought, the polysaccharide vaccine, 23 valent, I thought that was good enough, and it's not, because of, the evolution and the technology, the ability to elicit a more robust immune response, and an immune response that has memory, lasts longer, right? So that's very, very important. The other thing that I've heard used that makes a lot of sense is the valency's change. It's like conducive to whack-a-mole. Right?
Oh, yes.
So some seasons you get some, others you get others, and you try to, you knock some out and other ones pop up, right? So I think the question I ask you then is, how do you approach the patient that says, John, I was in here, 2 years ago. You told me about Prevnar 13. Now you're telling me there's a new one. Both of them I'm paying out of pocket. What should I do?
Well, I think it's opportunity, right? There's disease causing serotypes as especially when you vaccinate the kids. So kids started getting Prevnar 13. It limits the transmission to adults. So as you get as you start to see a reduction of those, your whack-a-mole, what we see is what we call serotype replacement.
That's right.
So these bacteria, these pneumococcal strep pneumobacteria, they're constantly trying to, it's an arms race, right? So are you going to arm yourself against this potentially devastating infection? And if someone has purchased Prevnar 13, then that's probably a good candidate to talk about Prevnar 20.
Yeah, that's right. I know. And I think, once you have one of those vaccine-friendly individuals, it's made an investment in their health, they're much more likely to get vaccinated with something new or something that's going to protect them at even a higher level. And I think the second question we ask here is, we've been talking about pneumococcal vaccination. You and I personally told audiences all over the world, but we're not seeing a lot of movement. And it's not just me and you, it's all the experts in Canada and everywhere else. So how do we get this message across, And I think maybe some of the approaches we've been using haven't been working because we haven't really moved the needle. Right?
No, we haven't. And I think that's where pharmacists play a huge role. And that's where we talk about the COM-B model of behavior change. Capability is understanding pneumococcal disease, understanding the options. We've reviewed that today. The other two are really important. That's opportunity. What opportunities do pharmacists have to recommend and administer pneumococcal vaccination? And the last one is motivation. What is the motivation to do so? And if you address all three, you get behavior change. So what opportunities exist for pharmacists to identify patients at risk, have the conversation, and ultimately administer the vaccine?
Yeah, and I think when I think of opportunity, there's never been more opportunities in pharmacy than today.
Oh yeah,
right?
Yeah.
If you go back even 10 years ago, I mean, we were immunizing for flu, but that was pretty much it at any significant level. And now, destination for COVID, flu, travel vaccination, all these things, right? And I think it's going beyond now simply administering the vaccine that the patient's there for, but taking that opportunity to talk about everything else. And we've, there's strategies we've been using with respect to consent now. We've been asking about other vaccines.
Yeah.
Good conversation starters. I know the technology and schedulers are being more commonly used in pharmacies as well. And, when you go to schedule for one, it may ask you for others, but just, getting the patient thinking about these other opportunities. And I think it's super important. I'll tell you, I'm in Greektown, senior ethnic patients, many Greeks, European elderly patients. They have no clue that pneumococcal vaccination is even a thing. Like, it's not even on their radar, right? It's still not on the radar.
No, it isn't. So it's kind of like, what are the opportunities just to mention it? That's it. You don't need to reinvent the wheel. The science is there. The evidence is there. The NACI recommendation is there. Is opportunities. So you look at things like diabetic meds check, right? It's like chronic disease patients. There's interventions. There's DTPs, drug therapy problems. A drug therapy problem is an immunization gap.
Yeah.
You are at disproportionate risk. If you have a patient who's diabetic and they're over 65, double whammy, right? Yeah. So double whammy is, did you know that you are at higher risk for pneumococcal disease? This is the vaccine that's recommended for you, right? Yeah. So it's that personal recommendation that's very powerful. Now, cost isn't the biggest thing. We talked about that.
Yeah.
It's perceived, and what happens, it's a negative feedback loop where you think it's a cost, you didn't recommend it, patient didn't get it because you didn't recommend it, right? So you made the decision for the patient. Your job is to recommend it, and it is to make them aware that there's a risk. And this can be done in clinical encounters, travel consultations, right?
For sure. Absolutely.
Older adult patients are traveling.
And, absolutely traveling. And I think for me, what simplified the message, I remember having to present to pharmacists on this, and I was always worried. And especially if I was doing live radio or something, I'd get a question and you'd have to remember the algorithm with, Prevnar 13. What do you give first here or there?
Yeah.
The message is simple with Prevnar 20. It's one and done.
Yes.
Right?
Yeah, there you go.
That's how you remember it, folks. It's pretty straightforward. It's one vaccine, one dose, done. Now, there may be other scenarios if someone's had this or that, but when you're making that recommendation, the guidelines are pretty clear, no?
Yeah, they are. I think the recent NACI statement addressed all those permutations and combinations. At the end of the day, the pneumococcal vaccine space, there is some innovations coming.
Yeah.
However, at this time, all we can do is protect ourselves as best as possible right now. And currently, the NACI statement compares currently available pneumococcal vaccines and the conjugate 20 valency vaccine, Prevnar 20, is the recommended vaccine. And I think the big thing is implementation strategies.
Yeah.
I think our listeners are going to be like, you know what? Great review, Ajit and John, pneumococcal disease, vaccination. Where do I add this vaccine in? Our last episode, we talked about influenza and COVID. So I want to open up a debate here. Is what is the best time to do this? Lung disease begets more lung disease. Yeah. Somebody coming in, co-administration, flu, COVID, Prevnar 20?
Yeah.
Or is it our year-round vaccination plan where we're so busy during flu and COVID season where we should focus on doing that safely and then parlaying the vaccine into other parts of the year? What do you think?
I think it's the latter, the second one, for sure. And I'll tell you why. I mean, it's easy for us to say give 10 vaccines during flu season or whatever.
Yeah.
And I know your personal record, we always bring this up, is you've given a ton of vaccines in a single patient. But the reality is, to most patients, I find even 2 is kind of pushing them personally. Mm-hmm. To say I'm giving you a third, it's sometimes a hard sell. I mean, it's not that you won't get patients that will do 3 at a single time, but it's going to be more difficult to convince the patient that it's safe, effective, and everything else. I think the strategy is, like you said, make immunization a priority year-round.
Oh, yeah, definitely.
If you engage your pharmacy technicians, engage your staff pharmacists, make them aware that this is going to be something you're going to be offering in your pharmacy year-round. Make it a team approach. It becomes routine pretty quickly, I find. And there's different ways. There's no cookie cutter approach. I talk about this a lot as well.
No, it's a good point.
Every pharmacy is different, right? Different volumes, different demographic, different number of staff on hand. But I'll tell you, it takes a little bit of courage to invest in immunization outside of the immunization season and say, you know what? Instead of cutting back here and doing this, I'm going to invest a little bit of labor and try to build this business because it's a huge opportunity.
It's huge. And lung disease begets more lung disease. Clinical services begets more clinical services.
100%.
So it is the future.
Of course.
Well, actually, I would say it is the now.
Yeah.
It is the now. You talk about it all the time. Dispensing revenue shrinking. We're going to drones, for example.
Yeah, we're flying drones soon. And we know that shared services are central fill. It's a reality. Like you look at my store, high volume store, 60% of the scripts, over 60% are out the door. We don't do them there anymore.
Yeah.
And honestly, I don't want to do them. It frees up time for my pharmacist to do everything else. And we're still busy dispensing. You know what I mean?
Oh, yeah.
So if that central fill disappeared, I don't even know how we would handle the volume in-house. It'd be impossible. And I think we've got to, the dispensing game is going to be a race to the bottom. We're going to need to use tech to do it and do it efficiently and do it where it's still economically feasible to offer the service. You know what I mean? We're still a business and we want to be profitable and everything else. So I don't think there's any coming back from that. Those pharmacies that are holding on to dispensing, you're losing an uphill battle right now. It's not gonna be there in the next 5 or 10 years. It's gonna totally be gone. And what's gonna be left is what we're seeing in stores like Mohammed Al-Sabakawi here in
Yes, yeah.
Mississauga or Fabio Durango, these future pharmacy stores where they're very unique, very innovative. Dispensing is almost become second fiddle to the clinical
Oh
role
yeah,
of the
they've got
pharmacist.
concierge, health concierge, and it's just a fantastic opportunity to be the place where these invaluable tools for healthy aging and longevity are able to be brought up and
We should
recommended.
get one of those guys on a future
Oh,
episode.
we definitely
And,
will.
yeah, get their
Yeah.
perspectives because I think in Alberta there's a lot of this going on, and many of the pharmacists have seen it. I think in Ontario, and I would say BC as well. There's not many in BC, I don't think, if any yet. I think there's an opportunity to, for pharmacists to hear a little bit more about it, and because you talk to guys like Fabio or Mohammed, and their patients are coming in looking for services. Sometimes it's services you don't even offer. Guys are coming in, I broke my arm, could you help me?
Yeah, yeah,
But
yeah.
it's becoming a destination, and I
It
think
is. It
where they're
is.
doing most of their work is chronic disease management. But beyond that, it really is immunization, and they're seeing a bulk of patients across all therapeutic areas.
And that is an excellent kind of summative statement there, John, is it's not just immunizations, but immunizations are a huge part of it. So I would say probably a 90-10 or an 80-20 split of our debate, where 10 to 20% you could throw a pneumococcal into the flu and COVID conversation. You will have some patients who are motivated and they'll be like, I'm here, give me the shot. But you can't load everything up in that one window, especially when you made the infrastructure investment.
Yeah.
So you've got to have a calendar of immunization campaigns.
Yeah,
And
I
pneumococcal
agree
vaccine
100%.
is a very critical one that should be done to protect the same patients you're vaccinating for.
And it could be, during that, flu COVID season.
Yeah.
That's, you're starting those discussions as you're vaccinating. Have you thought of pneumococcal? They don't have to get the vaccine at that time.
No, even incepted the idea.
Yeah, you
which is
just
something you
planted
need.
that
Yeah.
seed, and when
Yep.
you see them later on in the year,
Yep.
you get the jab in that,
Exactly.
But I think it's a real low-hanging fruit for us. I mean,
I think so.
we haven't moved the needle. Let's set a goal for our audience. Go back into your practice and
Yep.
think about, as you're planning for COVID flu season, the typical respiratory season, what's my plan going to be for pneumococcal vaccination?
How am I going to move the needle? The 80% challenge, right?
Yes.
Of all your patients, all your regulars that come for your flu shot, that ask you in the summer when the flu shots will be available.
Yeah.
Snowbird patients.
That's right.
Right? I'm going to Arizona. Can I get my flu shot there? Are they vaccinated against pneumococcal?
That's
So
easy starting point there,
So with that, always a pleasure, John, to talk about pneumococcal disease. But over to our listeners is you can make a difference. That's your launching pad. Let's go.
Do it.